100%.
Oh, share with the audience. Quick share, and then you can share stuff
Oh
from there.
gosh, those are the worst
From
kind
here,
of visits.
if you want to share with the audience. Like this, if you want to share
So
something
I guess
with the
probably
people.
like Capitol Health and. Oh my gosh. Oh my gosh.
40 years of stories.
On which one?
I bet. That's crazy.
I didn't know if you had to be subscribed or not. Okay. So then.
Randy, you're probably working not by choice. Sort of by choice.
It showed up in the phone. It
Still in
showed
the grind.
up.
That's all right. I do like organizational change management for pharmaceutical companies.
Okay.
Kind of on the same order.
Sitting there, something needs to be better.
So in here,
Yeah.
you can see it right there, right? That's where you're going from there.
Brendan and I were just talking about how there's a lot of pharma around here.
Mm-hmm.
You work for one pharma company or?
BMS.
Home.
Oh, nice. You work on site?
And then you can look for it.
Okay. Not that it's that far, but.
I still have time between the one here and it's like up in New Brunswick, off Route 1.
Okay. Yeah. Okay, not too far.
That was all right.
Yeah.
She's doing okay.
Just started a year ago. She got recruited. Their sign-on bonus was really wonderful. But strange for her not doing patient care and instead doing but she travels.
Those are shorts.
She was in Boston.
What did you label it?
The same watch YouTube live. There's one person. Nothing. It's just watch YouTube live. That's you. Yeah. Oh, that's it. Maybe it just took some time. No. No, don't report. Good. Got it. No, actually, it says 3. Okay. That's your player. Chat is disabled for this live stream.
Maybe people can email in questions at some point.
That's not what it said. Tell you what you want. Okay. Because it was clicked when I checked on it. All right, so what we're going to do, because without further ado, isn't that how you say it? Yeah. Yeah, so what we're going to do, if we have the questions, why don't we? Yes, that was the other thing is that you can also go through, if you have Facebook or Instagram, but then that's yours, so then you don't see it. You won't be able to see it. Right. So what we're going to do, trying to think what would be the easiest one. You can't see. Okay. On Facebook. Yes.
I'll just do that.
On the comment of. So go to our Facebook website or Facebook page. Yes. And in there, scroll down till you see the latest ad for the workshop, and then you can do the comments there. Now, the trick's going to be if you do not have Facebook, some people don't have Facebook. Well, no. But you could call.
Why don't you come visit?
No, you could literally call 609
Yeah, come on.
0366. My other
Love
thought
that.
was you could also contact us through our website in the contact us
Now
page.
answering.
Go through the website
Yeah.
in the contact us. Type your
Happy to.
question, submit. It's for the patient live. So Easton, every so often you can just check our office email and then we'll be able, that'll pop up. You might also be able to see it through the Wix in the website. Do you know what I mean? The Wix app. Okay, so without further ado, if you don't have, apparently the chat's not, the chat is disabled, which it wasn't. So anyways, this is why I should stick to physical therapy, okay? And so, again, comments, you can find the comments by going either on the Facebook page, on the latest post for this workshop and just comment there, or you can go to our website, fluidphysio.com, contact us, type your question there, or 609-436-0366, our phone number, and we will all hear it, and you can call us live if you're in fact watching this live. So thank you for putting up with all of this. Without further ado, Dr. Sassy Weinstein, sports medicine physician. Tell us a little bit about yourself.
Yeah.
Oh, can we lower that a little bit? Unless you wanted to leave it a little on.
We're good.
Okay.
Cool with whatever. Yeah, great to be with you guys here. Thank you, Gianna, for having me. So awesome to kind of collaborate with you guys. Yeah, I'm a sports medicine physician, family medicine trained. Went on to do sports medicine fellowship and also lifestyle medicine board certified. So I kind of integrate all of that into my practice. Treat patients with kind of very holistic point of view, even if it's just, knee pain. There's a lot more knee pain than just the knee. So today we are going to talk about knee pain, and obviously this is super informal. You guys ask questions, stop us, any other questions, concerns, anything, just let us know.
Cool. Dr. Gianna Bigliani, physical therapist, and I'm the owner of Fluid Physio. And so we've been around for 9 years now. We specialize in mostly orthopedics, but we get a significant case of some neuro and the majority is really complex cases or people that have tried other places. And we really do take the time to look at the whole person, not just the knee, because as you guys will learn, the knee pain has a whole reason why it's giving you problems, and it's often not coming from the knee is the source of the problem. So
I guess I should
Yes.
mention my practice is core sports medicine
There we
and
go.
lifestyle medicine. I actually just recently opened this practice back in November. Yeah, so I was at a big orthopedic group prior to that, had another little job, and then now I am just started my own practice. So totally solo, treating patients the way they deserve to be treated and with the time that they deserve.
Cool.
Yeah.
Let's talk about that knee, shall we?
Let's do it.
All right. So if you ever want to do this, we have bone stuff under it. The other one's fine. You can draw on it. You can
Awesome.
draw over there.
So kind of the first place that we need to start with knee pain is some anatomy, right? So knee anatomy 101, right? And so what comprises the knee? We've got bones, we've got cartilage and the meniscus, and then we've got muscles and tendons, and then we've got ligaments. So we've got this handy dandy model here. So starting with bones, right? We have 3 main bones that comprise the knee. Thigh bone, which is our femur, then our 2 lower leg bones are our tibia and our fibula, okay? So those are the kind of 3 bones that kind of make up the knee joint, but there's a lot of other structures that surround that area to give it stability and structure. So the other things that surround it are ligaments. So we've got 4 main ligaments of the knee. Ligaments connect bone to bone, okay? So we've got ligaments on the inside and the outside of the knee. That's going to be the MCL, or medial collateral ligament, and your LCL, your lateral collateral ligament. The names, luckily, they like pretty much do as they say. So they provide the stability on the sides of the knee so that your knee is not like wobbling back and forth that way. You then have, if you can see in the middle here, if I bend, it's probably hard to see, but you have two ligaments that cross over in the middle, okay? Your ACL and your PCL. ACL stands for your anterior cruciate ligament, and PCL is posterior cruciate ligament. So those two cross over to prevent anterior and posterior translation or movement of the knee. So I'm sure everybody knows somebody that has torn their ACL, whether, you know, an elite athlete, a friend, whatnot, but often an injury that we hear of and we're like, oh, like that stings. That person is probably out for the season now because it provides such stability to the knee. Then we have cartilage. So on the end, if you guys can kind of see here, on the ends of all of our long bones here, we've got nice shiny cartilage. So similar to like a chicken drumstick, you've got like really nice shiny cartilage on the ends of these long bones and behind the kneecap right here. And that is made up of a lot of different substances that help to provide lubrication to the knee, stability, elasticity, and allows our knee to function the way that it needs to. Then another type of cartilage is the meniscus. So I'm sure we've all heard of the meniscus. We've got a medial meniscus. So the meniscus is going to be these blue areas. A medial meniscus, which is on the inside, and a lateral meniscus. These are C-shaped pieces of cartilage that help to act as shock absorbers in the knee, or they help to cushion. And then we've got muscles and tendons. So a tendon is something that connects muscle to bone, whereas ligaments was bone to bone. Tendons connect muscle to bone. So the main muscles that we have around the knee are our quads, which are actually 4 separate muscles, and then they converge into one tendon, the quadricep tendon, which then kind of continues on to become the patellar tendon, which is right beneath the kneecap. And then posterior in the back, we've got our hamstring muscles. So a lot of structures, right, that help to surround and protect and provide stability to that knee. And with all of those things, obviously something can go wrong with pretty much every single one of them, right? And so I'll talk a little bit about what the most common things are that I see as a sports medicine physician, and then I'll have Gianna jump in and say, how they treat these from a physical therapy standpoint, analysis and all that. So first thing I'll talk about is something called patellofemoral pain. So patella, meaning kneecap, and femoral, meaning the femur. So in normal movement, the patella has to glide. Do you see this groove, like right here in the femur? That's called the trochlear groove. And so normally, when you bend and extend that knee, that kneecap should be gliding smoothly within that groove, okay? Due to muscular imbalances, biomechanical deficits, things like that, that kneecap may not be tracking correctly in the groove, okay? This is really, really common in our younger athletes, just due to muscular imbalances and sometimes improper training, which can then develop later on into arthritis as they wear down the cartilage. So when patients come in with that, typically they complain of anterior base knee pain. So knee pain kind of right in the front here, and often it's like right around that kneecap. So sometimes they'll say it's under the kneecap, sometimes they'll say it's right around it. When I'm doing an exam, I'll often feel the edges and the margins of that kneecap, and it's really tender because if that kneecap has been maltracking for a bit of time, it starts to rub in the wrong areas, right? Just like anything, if it's not tracking correctly in the groove, it starts to rub in the wrong areas and provides a lot of pain in that area. With time, you can actually start to wear the cartilage down behind the kneecap and along the femur here, and then that just leads to arthritis down the line. The treatment for this really is focused on those muscular imbalances and the biomechanical deficits, and that's why getting these people into PT really quickly and you know, usually this has been going on for a while, so it's not like it's, you know, very quickly, but if we get them into PT soon enough, they can start to correct those imbalances and those movement patterns. And so I'll have Gianna talk about kind of how she looks at these patients and kind of how they go about it.
Yep. So thank you.
Yeah.
A lot of the patellofemoral issues, it's tricky because, as I was saying, it's not all about the mechanical issues aren't necessarily happening as a result of the issue here. Sometimes they might be if you have a little bit of a shape that's a little different than normal, but it also has to do with what is your hip doing, right? Because if your hip, coming up a little bit, if you're doing a squat because you happen to sit down and stand during the day, if your hip can't control the movement or it's doing this because of muscle imbalances, because of tightness in the body, because of bad habits, then the forces of the knee, that knee can't really glide in that nice smooth groove. And so it starts to, a couple of things, when you're here, you're putting a lot of pressure through here, but then you have the tension from the IT band that pulls on that patella from that side, adding compression and irritability to both sides, because again, it's got 3 dimensions. It's not just, it's a groove, but then it can touch on the one side, touch on the other. The femur can be irritated, but the patella can also be irritated. You then tend to have irritability of the tendon, of the quad tendon as it joins on the top, or the patellar tendon as it attaches to the bottom. And so that's part of it, right? It's the hip's the problem. The hip doesn't know how to control it. Sometimes it could also be an ankle issue, right? So, yep, you can see ankle from here. So I'm going to show you with my own feet. When I was about 9, I broke my ankle. You like my socks? I broke my ankle. Although all I had to do, and when we evaluate people, it's not just like, yes, the knee. Yes, we're going to address those painful things by doing soft tissue release if the quad is tight, restrictions through the tendon, which you have something really cool for that. Mm-hmm. But mostly teach you mechanics. And then also we would mobilize through the ankle, right? Because I can take the ankle and do some movement to create more movement through there. Mine just, it was broken. It healed that way. I can give it a little bit, but it's done. Or I can do different modifications. So one of the things that I do is I usually have my lifting shoes had a little bit of a heel, because if I put a little bit of a heel, oh, I can actually go a little further because I'm giving myself a little boost, right? And now my knee doesn't have weird forces. I can control my hips, and oh, we address that. Sometimes it could also be lack of lumbar mobility. So if you're doing a squat and you can't hinge from here because you don't have this movement, I'm working with somebody who literally is like this. And so she squats like this because this doesn't bend. Well, here I am putting all the forces are going through the kneecap, patellofemoral pain dysfunction. Syndrome, I would say. It's like, oh, it's a syndrome because there's so many things that could happen, right? The majority of the places there's a little irritability places and we can find them, but it's a syndrome because it's just a whole bunch of stuff and someone's got to figure it out and help you. So it's not just like, oh, you got to do lots of like knee extensions, get your quad nice and strong. No, it might not even be that. You might actually be adding compressive forces that make it worse. So it depends. Everybody's a little bit different.
Yeah, John is totally on point. I think like anybody, I would say any of my prior patients who have seen me, I think anytime they come in with like anything lower extremity, I'm like, we have to work on glutes and core, right? And so that is going to give you your stability for the lower extremity. And so many people will ask me, like, what do my glutes, or like if I, give them some exercises, they'll say, what do my glutes have anything to do with my knee? And John is totally right. Like this provides your stability. So If I ask somebody to do a single leg squat with their hands on their hips, so you can see me, most people are gonna go in like that, or they're just gonna be like all sorts of wobbly, right? Whereas like everything should be stable, right? That means you're engaging the right muscles to control and protect that area. So yeah, totally agree. So let's move on to the meniscus next, because everybody always has questions about meniscus tears. What do we do about them? So as we mentioned, meniscus is the shock absorber, right? Then we've got medial on the inside and lateral on the outside. These can get injured. They can either be like an acute traumatic injury, so typically from like a quick pivot, twisting, like a quick squat motion, or getting hit, often athletes. Can happen that way, but a lot of people just have kind of like these chronic degenerative meniscal tears that can happen just from kind of repetitive stress. And again, if we're not engaging the right muscles correctly and things are just pulling and providing too much pressure on that area. So depending on what is injured here, if it's on the medial side, typically patients will have pain usually along the medial joint line, and it can go far back. So a lot of people can actually have pain behind their knee because it just depends what part of that meniscus is injured. If it's on the outside, they'll typically have pain over here, but again, it can be behind the knee. Often people will have pain with like deep squat motions, twisting, pivoting, changing direction, things like that. If somebody has symptoms where their knee's actually getting locked or stuck in a specific position that they cannot get it out of, or they feel like something is constantly getting stuck in their knee or like catching, or it's just really unstable, those are three kind of like warning symptoms to me that we have to, you know, probably get some imaging quicker because that may require something that actually needs a surgical approach. But the vast majority of meniscus injuries do not require surgery and can be treated non-operatively. Somebody have a question? No, you're good. Okay. Yeah.
So you talked about getting stuck.
Mm-hmm.
Why does a knee replacement get stuck?
Like
Why
if you
does your knee get stuck, then it's a knee replacement.
like post-knee replacement? So I guess the question is like, what does stuck mean, right? Like, is it a stiffness or is it like locked and cannot move?
Yeah, it gets locked, and then you have to move it with your hands, and it shoots up pain.
Yeah, it's quite, I mean, I guess it's what type of replacement did you have? When did you have it? The muscles around it, stiffness. Yeah.
I would say that what happens after a knee replacement is that oftentimes the soft tissue around the kneecap, usually the quad doesn't strengthen all the way. You just had a major traumatic event where they sliced through, open things up, change the bones, and then the quad for a long time, that was pretty hard to really lock it up, wasn't it?
Well, actually, I did very well.
Oh, good.
Since 2013.
Awesome.
Nice.
Locked up.
Yeah. So what I'm trying to say is at the beginning, the quad shuts down when it's been going through any injury, especially one such as the replacement. So it takes a little bit of time for the quad to get back to normal. So what happens in the meantime, as you're learning, as you're getting better, the quad gets really tight and knotted up and restricted. That sometimes when that's not fully released, sometimes it could be scar tissue that forms internally. That part of it could be scar tissue around that goes and joins the ligaments as the patella is sliding. So that again, if there's, now here's the other part is women's hips, because we have hips, the knees kind of come in. So if you have this angle and this can be tight, right, that can add tensile forces to where every time you sit down, oh, you're not putting any weight on it. There's no forces compressing through the kneecap, right? But you have tension because these tight muscles might be pulling it over. And so I might feel kind of stuck because again, you have grooves that in your replacement, it's all metal now, right? There's still a groove. Now, sometimes the back of the kneecap also gets cleaned up and they put a little plate underneath, and sometimes they don't. So that has something to do with it, right? But maybe when you're here, you have the soft tissue kind of pulling it off to the side to the point that it's like you go to move and it's like, oh, I got to push that kneecap and put it back in the groove, right? And so that, to me, it's more like a soft tissue restriction that just hasn't fully taken out, and possibly some muscular imbalances of why does it keep pulling that way? Why doesn't it, if you extend the knee, why isn't this side pulling evenly, right? So it could be a number of different things.
Yeah, and it can just be, again, mobilizing the scar tissue, and that can be a huge part of it too. So again, treatments for meniscus tears, a variety of factors go into kind of think about how I treat them. So 1 is the patient's age, 2 is their activity level, 3 type of tear, 4 size of the tear, and 5 kind of where is that tear located. So for, again, most of them, if it's not causing restriction in the joint, causing that knee to actually get stuck or locked, then we can deal with most of them. The meniscus actually has different zones based on the blood flow and the blood supply. So tears on the outer zone or the red zone have a much better blood supply, and they are more likely to just heal on their own, whereas the inner 2/3-ish of the meniscus is more of like the white-red zone, less of a blood supply, less likely to heal on its own. But there are many things that we can do about that kind of treatment intervention-wise, which we can kind of get to. Do you want to talk about anything else from like a PT standpoint?
One of the things that I wanted to talk about is a lot of it, the meniscus aspect of it, it's weight bearing. So oftentimes people will have more pain when they're going down the step. They're really loading and they have to control that. When it's more patellofemoral, it's often, I have more pain, patellofemoral or arthritic type changes. That's more pain up the steps. It's tricky when it's both ways, huh? But coming down the steps, we were talking about that movement. Well, you have that cartilage that's supposed to support you on top of the meniscus. And if you come down and you don't have the control to descend, except you come down and you're like roll in and you're not aware of it, that can create wear of the joint in different ways, or in that the meniscus can have a little, if it's degenerated, something. Is that right?
Degenerative.
We haven't done workshops together, but so English is my third language, and sometimes it's like what? Reset. It wears out a little bit more on the inside because that's just sort of the majority of the angle. But you want to learn how do you do that? So oftentimes we'll train people as, yes, we have to load the glutes. This loads the quads just because you're coming down, right? Well, first you have to make sure you get those glutes loaded. So we'll do bridges, because if you come down and you load the knees, you're going to have pain, more so here. So, and the ankle has to have good movement, right? But whenever the knee comes in front of the toes, that creates more load in the kneecap. Also, when you're going down, that puts more load on the meniscus. So what we need to do is train to learn how to put the weight through the glutes, right? So we can train, now this is a little high for someone who's just getting started, but sidestepping are a nice way to teach someone that they have to keep the load in the glutes. I'll show you guys from this side, so that it keeps the knee out. There's a couple of different ways where in manual therapy, part of manual therapy, it's not just moving the joints or soft tissue release, but I can just sort of give people feedback with my hand that keep your knee over there. Don't let it turn out. And teach people to turn on the right muscles, okay? Some of the parts that sometimes when there's a meniscus issues, people will say that, my knee's I can't straighten it all the way. So we have to look at, posterior aspect of the knee is that tight and restricted. Because they'll be like, oh, well, yeah. So again, remember I was telling you about my other knee? Yes, there's a little meniscal tear thing that actually it's no longer showing in the MRI. But it would get stuck. It's like, I can't really fully extend it. So one of the things that we would do, does anybody have issues with full knee extension that wants to show off? Okay. Well, just do you mind?
Yeah. You want me to lay down?
Yeah, or just sit. It's fine too.
Which way?
Let's, either way works. Is there a knee you don't want me to touch? For
No.
whatever reason? I don't know your knee. So one of the things, so ideally, we want the knee to fully extend, right? So Dr. Sassy here, she's being nice by not putting her sneakers in the table.
That's right. I saved your table.
So she goes way up there. Amazing. So in her case, she's going to really need to learn how to control those hip movements because she has so much movement that if she doesn't control it, that meniscus is going to really wear. So let's just say, oh my God, her meniscus got stuck because so many extra forces and it's stuck and I can't, well, this would be really painful. So one of the things we would do to gain that is we could do a little traction where we create that extra space. And once we have that traction, I'm going to do it from here. So we pull and then we do a little extra forces to stretch the posterior capsule. Definitely not something Dr. Weinstein needs. The other thing, now come all the way down. I'm going to be here. Sometimes with meniscus, you can't bend it all the way, right? And yes, sometimes it's movement of the patella, but sometimes it's, oh man, that little meniscus thing, you're going up, by the way, sorry. Sometimes it's like, oh, that's like really stuck. Good. But I can't move it. So what we do is we create space in the joint. So we can take people, find that joint line. And the idea is now the one way for extension is long axis distraction. For flexion, we want to get some more flexion. This isn't the best side of the table because I have some space here, but you'll do okay. I can actually lock her foot and do a little bit of distraction. Now here, see, it's not good because you can see her whole ankle move. Go that way. Look at my butt. There. So I can come here, scooch back a little bit. Yeah, and I can sort of bring it down. A lot less movement here, right? So what I'm doing here is creating some space. And once I create the space, then I can kind of move back and forth because what I'm doing is extending the kneecap or flexing the kneecap, right? Here it is. I'm pulling down on the foot so it creates extra space. And within that space, now if there is a little sort of like hook of that little torn meniscus, then I can mobilize it and be like, hey, get back to place. Our body wants to heal and feel better. So I think of meniscal tears as like little hangnails. You know how and then they get stuck places and you're like, oh, I just want to cut it. Kind of like that. They just get stuck places and every time it gets stuck, it keeps pulling and getting irritated. So open up the space, clear it up, make sure we do movement, restore strength, because oftentimes people don't realize, oh, just walk funny.
Yeah.
And normal movement patterns. And there we go.
And core stability.
Because you have to stabilize the core on the pelvis, and then that way the knee doesn't have the stuff. So yes, they're all sort of going together. That oftentimes what I've found is like, oh, well, my knee hurts, and they really treated my knee, and they mobilized my kneecap, and I did all this stuff. But it's like, it's learning how do we join the whole body together, right? Because if you're going up the steps like this, because you sit like this all day long, well, that's a whole movement pattern that we need to change. And so it can be as simple as, oh, we'll load up the glutes, but also as tricky as realize that you're transferring the weight with your whole body, just like Dr. Weinstein was saying, when you're doing that single leg squat. This is easier if I have a good core than if I'm like this. Then that's actually uncomfortable. I don't want to do that. So the whole body.
That's right.
There you go.
Any questions about meniscus, meniscal injuries? We'll talk a little bit about kind of interventions, kind of other things that I can do as well. But we'll talk about kind of some tendon issues. So whether that's the quadricep tendon, whether it's patellar tendon, the hamstrings in the back, our tendons can get affected mostly from overuse and kind of recurrent stress patterns, especially if we are doing the same thing all the time. So our athletes that are constantly running, jumping, sprinting, but also like our occupational laborers who are doing similar things and constantly engaging that and may not necessarily be, again, core glutes strong enough that so much stress is going through those tendons now too. And so oftentimes you guys probably hear the word tendonitis, right? And so everyone's like, oh, I have tendonitis, right? And so that word, itis, literally just means inflammation. So inflammation of the tendon. We see some inflammation within like a few weeks, like maybe a month. Like you would see it if I put an ultrasound on you, you could actually see, inflammation in that area. You don't see inflammation on an x-ray, by the way. But once you get past that, and this has now become more of like a chronic issue, like months to like years down the line, this is no longer a tendonitis. And we have now kind of transitioned into what we call tendinosis or tendinopathy. And that's more just of a chronic tendon injury or stress. And we can actually see changes in the tendon structure on ultrasound, on MRI. And so that tendon, in response to this chronic stress and injury, actually gets thicker. The pattern, which is normally what we call like a fibrillar pattern and is like nice and kind of like in line with each other, does not look like that anymore. It's thicker. It's just, it looks a little bit like off, essentially. You can even get some small partial tears. This is all normal things that we see with this chronic tendon injury. So when I tell people, yeah, like we might have like some partial tears, they're like, I have a tear? Like why has this not been treated? This is just like a normal part of chronic tendon changes.
Because you're humans, by the way.
Because we're humans, yeah, and we all have it, right? Because we are all humans. We move. Sometimes we move in ways that don't agree with us and stress areas that we shouldn't be. But most people have had some tendon issue in their life, and the treatment for this is not to totally rest it, because tendons need to work to get better. They just need to be worked in the right way. So a lot of people will be like, oh, I took 3 weeks off and did absolutely nothing, and then as soon as I went back to doing something, it started bothering me again. It's because your tendons actually need to work to heal, as opposed to if you fracture a bone, your bone needs to heal, and like your bone needs rest to heal, and not to be weight bearing depending on what happens, but tendons actually do need to work a little bit, which is why people with chronic tennis elbow, golfer's elbow, hamstring, quad, you need to be worked in the right way, and your treatment will differ as well compared to me who treats like arthritis or something that is more cartilage bone related. Tendons need you need to stimulate healing of that tendon. And that's where certain treatments that I do come into play. And again, Gianna's expertise here comes into play as well, treating those.
So for tendons, they're going to be, so what we mean by tendon, a tendon joins the bone to the muscle belly, right? So we have the muscle belly and the bone. This is, people call it the patellar tendon, but it's kind of like a ligament.
Yeah.
It doesn't really have muscle.
Bone to bone.
Yeah, because it's ligaments meaning bone on bone. We always say, oh, but patellar tendon, fine. The fibers really do also go all the way up. Call it whatever you want it to be. But the idea is that we still want to add tensile forces. And so for tendons, the majority, because the top of the tendon, the one that's closer to the muscle belly, has some contractile units, we want to stimulate it by doing eccentric loads. So one of the things that we do, actually, let me pull this over here. I'll walk back. For patellar tendon, that's a common one.
Let me see it.
Yep. we will have something. So you know how we were talking about the step and it's like, ooh, that really loads the knee and the kneecap. And that's what we want. We want to load the tendon. So we will do something like squats in a slow position in this sort of descending way because it loads the tendon, nice, slow, and controlled. Sometimes we will do if it's one leg that's involved, we'll do it with one, but then that involves a lot of extra moving parts, so we'll do two at the same time, just doing some squats. That if that person has some irritability of the back of the kneecap, that's going to be awful. I don't want to do that. So eccentric load. So what is an eccentric load? An eccentric load, we're going to look at the quads, right? The quad, you guys know the quad stretches when you pull it back, right? So that's where it's lengthened. When it's contracted, Dr. Weinstein was talking about the tendons, but it's similar with the muscle fibers. When they contract, they do this. When they stretch, they do this. So an eccentric load is one that it's loading the muscle as it lengthens. So as I come down, I'm loading the muscle's tightening, but it's also lengthening because it's getting longer. So eccentric, lengthening of the muscle as it contracts, as opposed to concentric, which is when the muscle, so same quad, but the muscle is contracting as it, shortening as it's contracting, right? So this is concentric. The descent of it is eccentric. When I go up, it's I won't get you confused. The other way, if someone has a lot of issues with that, the other thing would be like, well, you can stay in an isometric, which you don't move at all, an isometric position. An isometric, for example, then, I don't know how to, part of the reason why I have tendonitis, maybe it's in the hamstring. That's another common one, is the tendonitis of this area in the hamstring. The hamstring actually comes from the back and it attaches right in the front. And part of it is often, they're loading the hamstrings because they don't know how to load the glutes. So every time they walk, they're like pulling with their hamstrings. It's because you're not using your glutes. So the other part of the tendonitis that we're addressing to heal is the gentle stretching. We don't really want to put lots of load on it. And I've sort of lost where I was going there. Gentle stretching of the muscles too. Where was I going with that one? I lost it. The isometrics. Yes. And then I had another and then two. Oh well, must be time, right? It's getting late.
About the tight hamstrings, and you may not be using your glutes.
You may not be using your glutes, right? It's another area of so for the hamstring, so it depends. If someone has the tendonitis here, right? Maybe we're going to do an isometric in a place. If they're overworking their hamstrings, part of it is, I walk with my hamstrings like this. Well, maybe. And then the other part is like, my knees hurt and you're loading your quads. So we can get you into a squat position to sort of hold it. We'll probably put a band here and help you feel, okay, am I standing like this? Do I feel my quads? Am I using my quads? It's like, wait, I want to use my glutes. So we can do an isometric position with very subtle changes to sort of teach you like, wait, I got to push through my glutes. There that is. And that way, if whatever's irritated, you're not putting a lot of load on it, but you can still strengthen it and add those tensile forces.
Awesome. Okay, last thing we'll talk about is osteoarthritis. Probably everybody's favorite thing, right? And so osteoarthritis, not the same thing as rheumatoid arthritis, not the same thing as osteoporosis. I get all those questions a lot. So osteoarthritis is the wearing down of kind of the cartilage on the bone. And so as we kind of talked about, all of our long bones have this nice articular cartilage, right, on the end of it. Due to a lot of different factors that cartilage can start to wear down. We talked about a lot of them here. A lot of other factors that play into it are lifestyle related factors, right? Weight plays a huge role because the heavier we are, the more force that's going through that joint, right? And so so that's why I talk a lot of lifestyle medicine along with that, because it's all related, right? If we can control the weight, that then controls the forces that are going through the knee. But as that cartilage starts to wear down, remember that the cartilage is made of this really nice matrix, and it secretes this really nice joint fluid that is really like nice, thick, lubricating. When that starts to wear down, that matrix and the environment within the joint actually changes. And so I'll often explain it to patients like, you know, it goes from a really nice, thick, lubricating material inside the joint to a more watery material, just based on kind of the substances within that matrix being degraded, essentially. And that's why we can kind of start to feel like more of that grinding and that like crunching sensation as that cartilage starts to wear down. But osteoarthritis is not just a cartilage issue, right? There's so many other factors, again, that are going to affect that joint. So kind of treating it and all the different, you know, biomechanical forces and lifestyle changes that affect this joint, that's where they come into play as well. And so with the arthritis, people's complaints to me usually are like, you know, your knee gets swollen every now and then, which, you know, after seemingly nothing, or it's stiff, you have limited mobility. So after a long car ride or a plane ride, or you've been sitting for a long time, you get up, feels really stiff, right? And then as soon as you start to move around a little bit, starts to feel better. So the old adage, you know, motion is lotion, is true, right? So the more that we move, the more we can kind of lubricate that area. But it almost becomes a vicious cycle, because when people are in pain, they don't want to move, then they get stiff, and then it's just, they're not motivated to move it more, when really moving is going to help them. So there are different degrees of arthritis. So from my standpoint, when looking on x-rays and imaging, there's actually 4 grades, 1 being the most mild, 4 essentially all the cartilage is worn down. When you hear people kind of like the bones being exposed. Bone on bone, exactly. When people are like, I'm bone on bone, that's essentially grade 4. And so treatment options for this totally vary. Again, I try to keep it, you know, start at the most conservative, non-operative way possible, getting them into PT again, core glute strengthening, mobilizing, getting you guys to move more. But oftentimes, if somebody is so painful that they can't move, and I don't think they're even going to be able to start PT, that's when I'll offer things like injections to kind of get them moving, and then have a more like long-term solution by getting stronger. Do you want me to talk a little bit about treatments for arthritis now? Do you want to talk about your role?
Yeah, it's pretty similar. It's like, how are they loading their body? So just because you come in, you know, a physician's going to give them a physician diagnosis. I have osteoarthritis. Okay. Or a meniscal tear. Okay. That's sort of the label, the ICD, the label that you're going to bill insurance, basically. But that doesn't mean that I'm not treating the arthritis. Arthritis is just the normal wear of the joint, and so be it. It's like white hair and wrinkles, right? It doesn't have to have acute pain. Excuse me. So what are we doing? Oh, mobilizing the hip joint so it takes the load off of the knee, teaching you how to get stronger so everything supports that joint. So it wouldn't really be, make sure you use the glutes. Glutes are our friends. Mm-hmm. Make sure you have good mobility and flexibility, because if you have, you know, bone on bone, well, oftentimes you're not straightening all the knee, getting the posterior knee capsule is short, or the hamstrings are short, or the quads get short. So the majority of the treatments for the knee issues that could happen can be the same, just because of the factors that influence whatever injury they ended up with.
Yeah, and so many, you know, if I look at an x-ray and, you know, I'm like, there's some wearing down here, patients will always say, well, how do I get rid of the cartilage? Or how do I get rid of the arthritis, right? We can't erase the fact that you have a little bit of arthritis, right? But we can certainly get you stronger, prevent the progression, and treat your symptoms too, right? If it gets to a point, which it seemingly did with Rosita, that nothing has worked from conservative measures, yes, then you get surgery and you get a knee replacement to optimize your quality of life, right? And I really harp on the lifestyle stuff here too, because again, this is about your whole body, right? And so if you are eating, a diet comprised of, ultra processed foods that are really high in added sugars and chemicals that our body has no idea what to do with, our body is in this chronic super inflammatory state, and that affects our whole body, right? So our joints feel that. So when I kind of explain it to my patients that way, like if we can clean up the diet a little bit, eat a more whole food, unprocessed diet, and explain to them what that means and educate on how to read a nutrition label and how to shop at the grocery store, that's going to affect the knee, right? Similarly, if you are super high stressed at your job, again, that sets your body into this chronic inflammatory state. So you see that like everything is integrated here, right? And so this, again, not just the knee, this is kind of treating your whole health from like a very holistic standpoint. Treatment wise, with the arthritis, again, we usually start PT, get on your home exercises that are kind of dictated by your physical therapist, continuing to stay active, a lot of times lower impact activities, swimming, cycling, walking sometimes. Elliptical, exactly. So those are lower impact activities that won't bother the joint as much. Like I'm not going to go tell you to run a marathon because that's probably not going to feel great. But staying active is really important. If it's so painful and like you're really swollen and you're like, I literally am not sleeping at night, my quality of life is being affected, that's when I typically offer a cortisone injection, usually at that time. And so really easy, we do it in the office. Cortisone is not going to cure your arthritis, okay? But it's an anti-inflammatory that's being now directed into the joint. I do it under ultrasound guidance. So I know that it's getting directly into the joint. It's going to calm that joint down quickly within usually like 2 days to 2 weeks. And then that can help you get into your PT and your exercise program. So that can really just kind of help you get started. Other types of injections that I do, you guys have probably heard like the hyaluronic acid or the gel injections, the rooster shots, all of those things. So that's essentially synthetic hyaluronic acid or joint fluid. As we talked about, that joint fluid is usually very thick and lubricating. And with arthritis, it turns kind of into a different watery substance. And so the goal of these injections are to put back in that really nice, thick, lubricating material. Those are usually a series of 3. You come in once a week for 3 weeks. We do the injection, same exact approach as a cortisone injection. Takes a lot longer to kick in, can take anywhere like up to 6 weeks to really kick in, but it theoretically lasts longer. And again, how people respond really depends on their degree of arthritis. If you have less wear of the cartilage, you'll generally do a little bit better. But I have a number of people who are like, severe, but they've never had any injections or done anything. And we do one and they're like, yeah, this worked for a year. So we do that. And then, other things that we talk about are PRP, which is platelet-rich plasma. This starts getting into more of those like regenerative therapies that you probably hear about on the radio or TV, stem cell, all that stuff, to help kind of stimulate healing in the area. That
is that used for arthritis or
can be
other?
Can be. Yeah. So honestly, from my like anecdotal experience, I have used it a lot for tendon. So chronic tendinopathies, patellar tendon, quad tendon, hamstrings. I've done PRP, and those people have actually done quite well. And then ultimately, there's prolotherapy also. That's essentially dextrose, which is a sugar. Similarly, can be used to help treat that with tendons as well as the arthritis. Tendons, I also now do Shockwave, if anybody has heard of Shockwave. So it is a machine that uses sound waves to help to stimulate healing and kind of like break up the tissue in the area. So really, really good for chronic tendon injuries, thinking like plantar fascia, Achilles tendinosis. We were just talking about a patient who's got a heel spur. So all these chronic tendon injuries can really help with that. I'm treating somebody right now for her Achilles as well, and that I think is going to be just an incredible use, and it's so non-invasive. There's no needle, there's nothing. The treatments are like 5-7 minutes, and then that it helps a lot.
So depending on what you're seeing, that's when
Yeah.
you recommend we're going to do X number of sessions.
Yeah, exactly. And like when I see patients, we go over like a full game plan and talking about, the most conservative, which is how I try to start off. I love procedures, but I try not to do them if I don't have to the more invasive. And again, depending if this is a tendon versus a, joint cartilage issue, treatments will vary. And depending what your symptoms are, what you've tried, it's all super individualized based on kind of patient and preference, right? Some patients say, I absolutely want 0 needles, and we figure it out. And then there's obviously, imaging along the way, x-rays, MRIs, and things like that.
One other thing alongside of the what are the different things that you can do, needles, shockwave, is we have it. It's been on the show the whole time, is the deep tissue laser. And so how does that work? It's another intervention, right? That sometimes the shockwave alone will do it. Sometimes the medication, anti-inflammatories will do it. Sometimes laser alone may do it. But ultimately, if you don't address the root cause, well, it might come back, right? Root cause being those dysfunctions that we talked about earlier. The deep tissue laser, it's using, shockwave uses sound waves. Deep tissue laser uses light therapy. And it is a laser, class 4 laser. So if I hold it in one place, it'll burn, but you don't hold it in one place. And what I tell people is that the light stimulates cellular metabolism. So if you've been stuck in a chronic inflammatory stage, it's sort of like push this and get over to the next stage of healing that's going to create new cells that's going to heal, right? So it's kind of like you put the plant next to the sunny window. Well, you don't want to just put it on one day and then put it back in, and then it's just going to be like, For pain, however, it actually inhibits the pain signals, and so for that, it can be really great. But ideally, I invested the machine just because it actually speeds up healing. So then you put the light, 6 treatments is our minimum treatment. 6 treatments, and then now the cell's metabolism speeds a little bit up, and then a little bit more, and then that sort of your body takes over, and there we go. So I've had great outcomes with someone that's had shockwave that still had a lot of pain, that then we use the deep tissue laser with, and that's sort of like, oh, there we go. And then it also helped by speeding up the metabolism, then the calcifications, bone spurs that get broken up by the sound waves, your body has to absorb it. So then speeding up the metabolism can help the body absorb it too. So this is another one that for pain or things like that, it's totally non-invasive. The only restriction on if people have tattoos and it's kind of like light, you have a dark t-shirt, you get hotter outside. So don't do it with that. Or obviously pregnant and probably similar to the contraindications.
Yeah, there's so few active cancer at the site.
Cancer, period.
Pacemaker.
Shockwave. That's it. But you can do it over. Yeah. Over like if.
And there's so little, and there's like essentially no downtime. Whereas like someone with PRP, I would have take some load off the area. Afterwards, it's also pretty painful. Shockwave is like, okay, you can move on.
Shockwave is this one or this one?
That one.
Okay.
That one.
Shockwave sound.
Okay.
Yeah.
Laser light.
And shockwave, you said, wakes up the bone spurs?
It can, yeah. And it really helps to, it actually sounds like a jackhammer, kind of. While you're doing it, yeah. Okay. But like the person I'm doing it on now, she's like, this is like such a good hurt, because like you feel like it's just getting to that area that has been so chronically overworked. And so, yeah, it can really break that up and start to stimulate healing. And again, helps to block the pain receptors, similar to the laser.
Yeah, so it's just different ways of doing the same thing, which is getting you back to what you want to do.
Yeah. Or with a needle, what if I try to break it up physically with a needle?
Yep.
which I can do also. Like if somebody has a calcification,
Oh,
like a bone spur, yeah,
Mhm.
you can break it up.
Yeah. So again, different things and different exercises. I can give someone an exercise for a bridge with a different reasoning and different purpose than someone else. The same thing with the heel stuff, right? With the step up, right? Not every exercise is the same. When people say like, "Oh, my knee hurt," and here, try this, do this squat or whatever. It's like everybody's different. So ultimately, an individual plan, looking at your life as a whole, not just your joint, can make a difference between having this last years versus, oh yeah, I get this, and now I want to get back to running, or whatever it is that you want to get back to that you're not doing.
Yeah. I think both of our goals is to get people back to doing what they love, and having the best quality of life that you can have. And so figuring out how to address that from just multiple different avenues and having great teams to work with is how you get better.
Did anybody have any specific questions that they didn't get answered with our talks, or that you want to bring up? You had some good questions.
Okay.
So yeah.
So I play softball.
Softball? Love it.
And it's been the cause of every emergency room visit, I think, except one. So by far the worst one is, these are old injuries. So I had a tendon injury, and then I had laparoscopic surgery. He was going to just tack the meniscus back, and then he got in there and was like, ooh,
Yeah.
because it had fused.
Okay.
So he just cut it out and took it out. Then I had another injury. I had a tibial plateau fracture.
Okay.
So I don't know. I think I was on crutches for 2.5 months.
Oh
And
gosh.
it healed. And then just over the years, it's just that piece just eventually just wore off and it was gone. So I have like instability back here because of that.
Yeah.
Obviously, the meniscus part of it's gone, probably all gone. Got some bone on bone. So I know just based on what you're saying about trying to rebuild strength in different parts, because I can play ball. I have a knee brace, custom fit. So it lets me do what I have to do to play, because that's the important thing.
Yeah.
To play. But if I could, improve it, I don't know, and it's probably more up here. I don't know that I could ever get away without wearing the knee brace to play. I don't need it for anything else, Going up the stairs is okay. Coming down, if they're like steep steps, it really hurts to bend this knee far back. So I'm sure things have moved around in there a lot, and they are what they are. So what would you suggest that, getting some strengthening? Or I had to laugh when you were saying using your glutes, because I was doing physical therapy one time, and there was like a band, because I was supposed to be working on glutes, and I was like, well, I don't think I'm doing it right, because I've never.
You don't feel them.
I don't,
right?
and I was like, oh, you're not even. I wasn't even there. I don't even know what I was doing, but I couldn't make myself get to actually exercising my glutes and strengthening those. So,
Do you want to go first? Me too.
I mean, I think
Probably similar.
it depends, right?
Yeah.
It depends on what else is going on.
Yeah.
Because ultimately, if the brace feels good and it makes you feel confident, then use the brace.
Yeah.
Is it worth it to like ditch the brace and like try to play and like be like all tentative and then
I'd never do it. I'd never
Right?
do it. But I just know that
So-
I could probably improve.
it depends on your like what do you want, right? Is the brace getting in the way of like my cute outfit on the field? It totally depends. Realistically, it depends on what kind of brace too, because if it's an offloader brace, is that the one? So then that's the one you definitely want to use.
Yeah.
That means and it makes a huge difference, because what that one's doing, it's using forces to take the load off so that you can continue moving. It's kind of like, how I was holding onto Dr. Weinstein's knees? That's kind of what that brace is doing. So you can bend and it's not going to have that. So that brace keep using it, because if you take it off, it's going to go back to gravity's going to keep pulling and
But yeah, in addition to that, yeah, strengthening and keeping the mobility of that area is going to be huge, right? And if you're still having a ton of pain, kind of despite all that, and like mobilizing tissues around it and strengthening and stabilizing core and glutes, like, yeah, we can always get some imaging and talk about further treatments to help improve the symptoms as you're working on those things and continuing to play.
Right.
because ultimately, oh yeah, bone on bone, what's the last thing? It's like, oh, it's a total knee replacement. That's like the thing, right? That's like, you think that that's going to be it. And it could be, but it depends. Is that going to then, you're still going to have to build glute strength. And if it can improve the quality of your life, you're the only one that gets to say, yes, I want to do it. Because there's tons of people out there that have bone on bone that don't feel pain and they still go play pickleball. So it's whatever you want. If that becomes so unstable because it's so worn out and everything's so stretched out that you go down the steps and your knee becomes unstable, and now you have a risk for fall because instead of coming down nice and smoothly, there's so much joint space that you come down but it tilts, and our knees aren't meant to move side to side, then that's another story, because you could be risking falling because your knee's unstable, true instability, not because of your hips, and that becomes another story. I had a patient like that was just so unstable. I had a video that the knee would just collapse. She didn't have knee pain, but it was the instability that ultimately made her life totally different. So, yes, it's all about your goals. Cool? Anybody else? Now, here's the other part is you guys, including those of you in that computer, phone, whatever, you guys sat through all of this. If you still have questions, you can always reach back to us. But what we want to encourage you, there's a reason why you came in and you wanted to listen, you wanted to learn, awesome. But if there's any issue, the biggest mistake you can make is to not do something about it, right? Because it's easy to, as busy people, got little kids at home, got people to take care of, got works. It's like, oh, but it doesn't really hurt that much. I'm just going to do my thing. I'm just going to come down and just whatever, right? So do something about it, right? That's the thing, because you can go get injections, you can do laser, you can put braces on, but is that addressing the root cause of the problem and helping your quality of life? So, is there any other closing remarks before I give them a treat?
No, yeah, I mean, we just want to see you guys have the best quality of life, and treating that from making sure that you're getting the treatment that you deserve and a very holistic approach, right? And so pain is a very real thing, and optimizing your quality of life and what you're doing is really important. So if you go to someone and go to a doctor, advocate for yourself, make sure that you're heard, and that's kind of what we're here for. So yeah, if anything comes up, make sure you let us know.
Of course, we believe that we are the best physical therapist and sports medicine physician, but it doesn't really matter. We truly want you guys to do better. So whatever it means, there's tons of providers out there. We do specialize in one-on-one care because there's reasons why we came out of the system to treat people independently. But ultimately, you can do something as an adjunct to an in-network provider. Use your therapy. You paid for it for a long time, even with your taxes, if it's Medicare, right? We just want you to feel better. So in that case where you can do just a consult, where you just come in, hey, I've been doing this isn't right, or I've been doing all this work over here, but there's one last thing that I can't do. I can't really come all the way down with that knee when I'm playing softball. Then you can just do a consult. But ultimately, we want to be able to help you guys get to whatever you want to get to. So one of the things to boost you, since you sat down for this whole time and dealt with me having all those technical issues, we have an offer for you guys and anybody that's listening today. It's just somebody made a sign. What we're doing, because we want people to do something about it, you guys can pass it over. This offer, one time only for the next week, something like that. We're going to have a physical therapy consult, a physician consult, where she can, Dr. Weinstein can look at your knee, see what's going on, give you a feedback.
Or any body part.
Or any body part,
Yeah,
that's true. We're talking about the knee, but
yeah.
this is definitely take care of yourself.
Yeah.
And 3 physical therapy sessions for a total of $775, which normally would be a little over $1,000. So that's another one that we want to make sure that we're working together, that you're getting the care we need. So this is sort of like a bonus to reward you for wanting to improve your life, wanting to get better. If you guys know someone, because maybe you're here because your friend has some knee pain, and like you're going to pass the information to your friend, you can tell your friend to watch the video and tell us, because we're going to be offering this for the next week, that people have been watching the video. That's the only way they're going to find out about this, is by watching the video or you guys telling them. So that's the only other thing. And so the way that it would work is you can schedule a visit with Dr. Weinstein first. You can schedule it here, depending on your schedule. Either way, to start with Dr. Weinstein, you can start here for the eval, and whichever makes you feel better, right? And the reason why it's 3 physical therapy sessions is because I would want to give you an assessment, mobilize whatever needs to be. And of course, there's always homework with physical therapy, right? It doesn't have to be 10,000 exercises. It could just be, I want to make sure that you sit and you focus on your hips and your knees not rolling in. That's part of the homework. So that's why there's 3, because then I give you the thing, you go do your homework, you come back in a couple of weeks. And also, if you're not having major knee pain, then it's like, well, I don't know why, but this always flares up every time I go to speed up my, every time I speed my running up, or every time, every beginning of the season of softball. What is it? So then we assess, we give you some homework, make sure you're doing it correctly, and then give you a little boost, make things a little bit harder, and then you can have a last one, check it out. So that's why there's 3. So
yeah, you can also follow us on social media.
Yes.
I put out a 5-minute workout every Monday, body weight only, so just to get people moving.
On what?
Instagram.
I don't know that.
Yeah, I do have a Facebook account also. Just Core Sports Medicine and Lifestyle Medicine.
Of course.
Yeah. So if you have my card, my Instagram is at Dr. Sarah Weinstein.
And in your website, you can add it as a blog. Do you have blogs in your website?
I do.
Yep. So every time you put an Instagram post, you created a blog with a link to the Instagram, which you're going to save, not as a daily Instagram that goes away, but one as a highlight or whatever. Maybe you have a highlight, and then you put it in there, and then you can just go right to Dr. Weinstein's website and check out her blogs.
That's right.
So then it doesn't die anywhere.
Learn something new.
And you said you weren't good with technology.
I am. It's just
I know,
the YouTube. My husband is